Hi everyone, welcome to today's webinar, Become a Medicaid All-Star, Practices for Time-Saving, Cost-Effective, and Compliant Medicaid Billing. Thank you so much for joining us. My name is Emily Smith and I work with Excelify. If you are not familiar with us, Excelify is a leading provider of special ed management systems. We are committed to supporting school districts and special ed staff in fulfilling the promises made by IDEA to students with disabilities. Our systems streamline every step of the special education process, including IEP management, service tracking, and Medicaid billing. So before we get started, I would like to take a moment to explain a couple of technical things about the webinar. So during the webinar, you can hear us, but we cannot hear you. So if you do have questions, please just type them into the chat box on your control panel. I will do my best to answer questions throughout by chatting back to you, and then I'll field as many questions as we have time for to Casey, who is our presenter today, at the end of the session. And I always get a lot of questions about this, so just to let you know, from the beginning, a recording of this webinar and the webinar slides will be made available to those who complete a short survey following the webinar. And last but not least, are on social media. And if you are, you can follow us to find out about future webinars, events, news, and contests. And you can tweet about today's webinar using the hashtag SpedChatWeb. So you can see there, you can follow us on Facebook, Twitter, or LinkedIn. So without further ado, I would now like to go ahead and introduce today's presenter, Casey Gayer. Casey Gayer is formally trained in public policy and has 5 years of experience consulting local governments on state and federal policies and fiscal management. Casey currently manages Medicaid and special ed program operations, training, and software implementation for Excelify's school district clients. This includes special ed management systems for hundreds of districts in dozens of states across the country. In addition, Casey is directly responsible for overseeing the implementation of claiming programs and IEP systems in new states, and works closely with Excelify's development team to ensure all systems meet state and federal regulations. Casey, we are very excited to have you on today. The stage is all yours.
Thank you, Emily. So today we're going to be going over how to become a Medicaid All-Star. First, we're going to go over a history of IDEA and Medicaid in schools. We'll review Medicaid guidelines at the federal level, and then we'll go over the 3 points that will help you become a Medicaid All-Star. The best practices for service documentation for your providers, the Medicaid claiming process and how to optimize that for your school district, and revenue maximization. Finally, we'll review some case studies that show where we've implemented these processes with our clients and the results of those efforts. First, a history of IDEA and Medicaid in schools. In 1965, Congress enacted Medicaid, which created a medical assistance program for individuals that met income or disability guidelines. Then in 1975, Congress passed the Education for All Handicapped Children Act, which was later renamed the Individuals with Disabilities Education Act. And this allowed students that couldn't quite meet the requirements of general education to receive additional services that would enable them to fully participate in the general education setting. In 1988, these two programs were bridged when Congress allowed Medicaid to be employed in schools so that students receiving services through the IEP could have the school district bill for those services back to Medicaid and recoup some of the revenue back that was being spent on these salaries. The Individuals with Disabilities Education Act has 4 purposes: to assure that all children with disabilities have available to them a free and appropriate education, and emphasize special education and related services designed to meet unique needs of students with IEPs. It assures that the rights of children with disabilities and their parents are protected, and it assists states and localities to provide education for all students with disabilities. Finally, it assesses and assures the effectiveness of those efforts through progress reporting. Now, a history of Medicaid in schools. Medicaid is a federal and state-funded health insurance program for low-income and needy individuals and families, with special eligibility considerations for children, pregnant women, and disabled or elderly persons. For persons under age 21, Medicaid may be known as EPSDT. Now, I want to touch back on this point that Medicaid is a federal and state-funded health insurance program. What this means is that the federal government and the state government both provide a share of the funds that go into Medicaid. And what this means for a school district in particular is that when services are billed to Medicaid, because schools are directly funded by the state, the school district only receives back the federal portion of that funding. This is referred to as the FMAP rate. Now let's review from some federal Medicaid guidelines. First, what makes a service billable? At the very basic level, a service has to be defined in the IEP, which is its form of prior authorization, and it has to be defined with certain requirements. The amount, duration, and scope of the service do need to be defined, and the medical necessity of the service does need to be established. Now, the amount and duration and scope of the service typically mean that you're defining 60 minutes a week of speech therapy or 2 sessions of 30 minutes of speech and language therapy. The medical necessity can be defined by any particular practitioner of the healing arts. So when a speech therapist does an evaluation and concludes that the student does need to receive speech therapy, that establishes medical necessity. Now, for certain service types, depending on the state you're in, you may need additional verification of this service. We typically see this for occupational and physical therapy services, where a doctor's script, either done by a collection to a single doctor at the district level or by the student's actual PCP, is required. Now, at the federal level, there are guidelines as to which service types are allowed to be covered by certain states. You may not see your state employ all these service types. They can limit the list as much as they would like. Those include physician and nursing services, vision services, hearing services, mental health services, durable medical equipment, case management, physical, occupational, and speech therapy, transportation services, audiological services, and assistance with daily living or personal care services. Every state, again, has the ability to expand or, remove services from this list. So you do see in certain states that a lot of these services are not billable, but this is what is allowed at the federal level. Finally, according to Medicaid, required documentation for services must include, at the very least, the date of service, the name of the student or patient, the name of the provider that's conducting the service, the duration or unit of the service, and the medical justification for the service, which is typically a diagnostic code. Finally, it must include if the service is in a group or individual setting. Most states have additional service documentation requirements, and we've seen these become more refined over the years, especially when it comes to going back to making sure that those services are leading towards progress and that the service is actually helping the student develop along with the IEP. Goals and objectives and progress notes that relate back to those goals and objectives are increasingly becoming important in service documentation. And as you can see in this image on the right-hand side of the slide, this is pulled from one of our systems where goals and objectives and progress notes are required fields for service documentation based off of state guidelines. So what are the best practices for service documentation? First, who should your providers document of all the students on their caseload? We do see a lot of districts that when we come into when they become clients of ours, I should say, are only looking at billing as Medicaid billing. And they're not looking at service documentation for any other purpose. And we actually make the case to every district that we began working with that all providers should document all students in their caseload that have IEPs. if not all students in their caseload entirely. Documentation is required for IDEA purposes. According to IDEA, if you didn't document it, you didn't do it. And if there ever is a due process hearing or something along those lines, you're going to want easy access to those records to prove that services did take place. If you do have your providers document all of their IEP students, the added benefit to this is they don't have to access the Medicaid status of any student. You can keep that information much more private and secure among a select group of people at the district. It also gives district administrators greater transparency into IEP compliance in general to ensure that their district is meeting the contractual obligations of the IEP for every student, and that you don't just have that information on students that happen to be Medicaid eligible. Finally, documentation requirements are then equally distributed rather than placing an undue burden of documentation on a provider that happens to have a high Medicaid ratio of students. Districts typically try and balance caseloads among providers so that they're all seeing the roughly equal number of students. But when you do have a provider that happens to be at a high ratio Medicaid school, their documentation requirements may be much, much higher, and therefore their workload much higher without a lot of transparency into that increased workload if you don't have the providers document everywhere. Or excuse me, on every student that has an IEP. Now, the other best practice here is to have a web-based system that can validate for all the other items like eligibility, parental consent, and those other factors, so that the provider just has to document what they're doing with the students, and it makes it more about service documentation. And in those web-based systems, hopefully like ours does, you can actually monitor at a percentage level just how much the providers are delivering minutes in the IEP. This sample we have here from one of our demo systems shows our providers and then how many minutes they've met at the IEP for their entire caseload. So let's touch a little bit more on that. Where should your providers document? This is where I want to make the case for a web-based system. When you have paper documentation, you receive the documents that are submitted, and then you have to go and manually enter those into probably an online billing system and get your revenue back. It can be a very tedious and time-consuming process, and it also doesn't give you a lot of insight into how much documentation your providers are doing. And then there's some other pitfalls to documenting on paper or documenting even in multiple locations. Perhaps you have your providers do all their notes for all their IEP students on paper, and they translate some of those notes into a Medicaid billing system. We've seen this actually cause some pitfalls when it comes to due process or meetings with parents. And in one particular situation I can recall, a provider's paper documentation did not match the online documentation, and the student was actually rewarded compensatory services because of that. Because just some notes weren't translated from paper to online. So there was no valid confirmation that the student did receive all the services since the documentation didn't match. And then the question also becomes, okay, so now there's an audit or there's some kind of legal proceeding where I need access to those records. If you have a web-based system, you can pull those up as an administrator with just a few clicks of the button. You're not emailing the provider and requesting the records and having them sort through their notes. You know, we've heard stories about file cabinets of notes getting lost in floods or other kinds of issues like that, or just being misplaced in a basement somewhere. And then when it comes to just regular review of documentation, you do want to be able to say, what aren't my providers doing? What have they scheduled but they haven't sent me yet? What documentation isn't complete? Fee-for-service billing, in a lot of ways, is about bringing a regular revenue stream into your district. So you want to be able to keep up on those documentation reviews as frequently as possible. And as I've already mentioned with the flooding and everything, you know, you do want a fully protected record of your services in case of disaster. Our company, as I'm sure like many vendors, has servers in multiple locations so that we have redundancies to protect that documentation and keep it full for the full audit review period. So what are the most effective documentation review practices? 1. Involve your department leads. when you do have that speech therapist or that OT or that PT that leads their own department and can speak towards the workflow and the process that providers go through, they're going to have a much better time communicating and expressing deadlines to providers and understanding where the providers are coming from when they push back on those. And they're going to be able to speak to the providers in a way that, an administrator who has never actually worked as a therapist can't, and give them suggestions on how to manage their time effectively so they can complete their documentation and still fulfill the needs of therapy every single week. And 2, adhere to strict documentation deadlines. We've seen this with different clients time and time again. The stricter the deadline and the more it's enforced, the more revenue the district receives. When you do have, longer deadlines, what ends up happening is the providers go back to paper notes, and then you're going to have those type A providers that do log every day or every week and catch up on things, or at least plan sessions towards the deadline to make sure that they have time to get everything done. And then you're going to have that provider that goes in and just does as much as they possibly can right before the deadline happens, and probably only logs 60 to 70% of what is actually happening and what therapy did take place. And then you don't get an accurate picture of what's going on. Maybe that therapist just chooses to log deliveries, but doesn't log why therapies didn't take place. And now you don't have an accurate picture of whether or not your providers are being pulled away for things like bus duty or something else that's preventing them from seeing students. And this is the kind of information that can help you make effective management decisions at the district level that will allow providers to get more help or to have practices change that will allow them more time in therapy. You do want all this information to be able to analyze. And another suggestion would, of course, be to include your documentation levels and performance reviews. Providers should be documenting, again, for IDEA purposes. It's part of their job to document what they do. And in any other setting, documentation is required in every single service provided. And again, going back to the case for a web-based system. When you have a web-based system, it does make that service documentation review very easy, and it makes it easy to make it as frequent as possible. Run a report, see who's left over, send emails, give a catch-up deadline, and then run reports again after that deadline has passed. So you're not sitting and waiting on them to send you something or anything like that, saying, oh, maybe they did it, but I just didn't receive the email, or whatever the case may be. If you're all housed in one single system where they can record and you can review, then it's a simple process of just accessing your own system to see what's been done in real time. So how can you incentivize your providers to document? Because as much as you can include this in a performance review, you do want the providers to feel included, and you want them to feel like they're participating in a program that's going to be beneficial to the district as a whole and beneficial to them. We know that these providers want the best for the students, and they know any additional funding to the district is going to improve their students' lives. So first, I would be transparent on the revenue generated and the funding allocations for that revenue. If they know that funding is going to go towards equipment that's going to help their students, or even books or supplies that may not be for special education but are going to help their students, that's definitely going to encourage them to document. If that revenue does in any way go back to the special education department, they should know about it. If you can convince your board to make any kind of allocation of funding, maybe, and we've seen some districts argue, say, okay, an increase of this much money should guarantee us a portion of that money for conferences or professional development or equipment. If you can have your providers set a goal of revenue and have the board promise that some of that revenue will go towards these things, that will definitely help them document a little bit more. If you can't quite reach a funding goal to get conferences or some expensive equipment, maybe just a couple of small things would help. A contest for recognition at the very least, just a certificate of those that have done a very good job in documentation, going back to just, here's how much money you helped the district generate, and you were a main contributor to that, and a thank you, an appreciation for all their hard work and their effort. Or simple prizes, a gift card to a restaurant or an iPad or something along those lines that will have them all shooting for something. And then the other thing that you can always do is say especially when you're looking at documentation systems, is the system I'm purchasing allowing me to reduce redundant documentation and practices? We've come into a lot of districts, and one of the best tools that they like about our system is that we have this calendar sharing opportunity where providers, when they document their calendars and they schedule their services, this can be shared with administrators so that they don't have to send their schedule to somebody via Outlook or share their calendar in multiple means. And our calendars actually can be exported to Outlook in some ways and record some details there. So it can give them a starting point, and they're not keeping this information in multiple places. And you'll see this a lot where the providers then, don't have to share their caseload with everyone if they do, work with case managers on their caseload and the lead needs it, because that information is all accessible from our system. And it reduces a lot of those extra processes where maybe if they did move from just Medicaid billing on, a few students on their caseload to full documentation, now that full documentation is supplying 3 different other tasks that they had to do every single week. So it's actually reduced their workload overall. And then the last thing that you can always want to look at is if you are using a documentation system, how well can it integrate into your IEP system? Can it help you build progress notes back for easy reporting on your 9-week progress report? Or can you transfer that data in and out? Everything in our system can be exported and imported, and we have that ultimate customization and that ability to sync with other systems so that you can transfer that data back and forth and make it easy for your providers so they're not writing the same thing 3 or 4 times, and they can just go and access those records and accumulate them for a progress report. All right, so let's review the Medicaid claiming process. Now, what determines an eligible service? Services must pass a combination of factors to be billed to Medicaid. We reviewed some of the things earlier about how they have to be listed in the IEP, but now we're going to talk about the claiming validations, what Medicaid will deny if these aren't valid. The student must be of a valid age, and they must have student eligibility. Now, the next things that we're talking about, these Medicaid will pay, but if you come back in an audit, Medicaid will recoup that money if these aren't listed. So as we said before, there must be a valid IEP or IFSP on the date of service. There must be an occupational or physical therapy prescription in place when your state requires that, and that is in most states. There must be parental consent to bill to Medicaid. The service also must be within the duration or unit of billing. So if that speech therapist did list 60 minutes in the IEP, in that IEP meeting, and then they end up delivering 90 minutes every week, and that is billed for 90 minutes every week, Medicaid may come back to recoup that extra 30 minutes of money. And finally, the service when in a group setting must fall within the group size limit. We see these range anywhere from a group size of 6 to a group size of 10, depending on the state. Now, how often should eligibility be submitted? Medicaid eligibility is determined monthly and can often be retroactive. If a parent has some kind of issue and they can't get certain application forms or renewal forms in time, their Medicaid will be suspended. And then in the files that are transferred back and forth every month, that student will show up as inactive in Medicaid. Once the parent does, work with Medicaid to get their eligibility in place, they'll often be granted a backdating for that eligibility status. So when you are submitting eligibility and collecting that monthly status on every student, the best practice is to go back and retroactively collect that, so that if you do have those retroactive statuses, you see them come through. And one of the things that we do at our company is we backsweep for the entire eligible period every single time on students that have a number but aren't Medicaid active, so that we can just make sure we've caught everyone. Now, how often should services be submitted? Now, the claiming process timeline varies by state, and it's best to know the timeline for each point to determine the frequency of submissions. And when I say each point, I mean, what is your timely filing limit for your regular services, that initial submission? We've seen this range from 4 months to 18 months to submit a service, depending on the state you're in. Then, when do you get back the monies you submit? We see the remittance advices return the following week or up to 6 months later, depending on the state you're in. And finally, if you do receive denials, what is your timely filing limit to resubmit those? We see that range from 90 days to 18 months from the date of denial. In most states, so long as your back billing period is 6 months or longer, we recommend that you submit your services about once a month, and that you delay that by 30 days, and that's the process that our company follows. And the reason we want you to delay that by 30 days is to give providers time to review their documentation. If you have that documentation of get everything in by the end of the month, and then claims are submitted the very next day, you may have that provider that crunches everything in the night before, and then comes back to you 3 days later and says, I put everything under the wrong student ID for this one kid, and now you've already submitted it to Medicaid. And you do have to go back and void those claims with the state, which can make your claiming process very, very messy. So giving time for between that deadline of documentation and at times the claims are run to let providers review their documentation and make any corrections that they need to really helps in making sure that you're not going to have to go back and make any voids with the state. And then when you look at the return of remittance advice, you want to build your denial review into that return of remittance advice. You want to make sure that you're not reviewing denials too frequently, that you're getting confused between what's pending, what's denied, what was denied and what was a resubmission and pending, etc. We tend to review denials quarterly here, and we tend to review them for the claims submitted in the prior quarter so that we know exactly what was denied and what was just pending in a regular claim. What was denied and resubmitted and what was pending in a regular claim. Now let's talk about maximizing your revenue. So what are the largest exceptions to revenue? What prevents services from being billed? First, we see this quite often with districts. Service types that seem very, very difficult to bill are ignored, and they're left out of the billing process entirely. And this is most often with transportation and personal care services. Then when it comes to services that are being documented and are part of the billing process, but certain validations aren't coming through, parental consent and OT/PT prescriptions are the next two biggest exceptions that we see. Parental consent definitely head and shoulders above OT and PT prescriptions. So what we find with parental consent is that in a lot of ways, parental consent is either not collected at all by a case manager or whoever's in that IEP meeting or that child study meeting that's supposed to collect the parental consent, or it's refused by the parent. And then on the OT and PT prescription level, we do see these collected pretty frequently. And for the most part, you don't see a lot of missing prescriptions. But what you do see is delays in collecting the prescription. The prescription won't come through for 6 to 8 weeks later, after that IEP takes place. And that prescription's good from the date of the signature. So the prescription is not covering that first 8 weeks, and you're getting a revenue loss right there. And then we have the missing IEP factor. Now this doesn't necessarily completely remove revenue from the revenue stream the way OT or PT prescriptions do. But what we see in a lot of cases is this delays revenue. And again, going back to the fact that fee-for-service is really there to create a steady revenue stream for your district. So when IEPs aren't locked in time and providers are documenting services, you may see a lot of services being documented but being withheld simply because you didn't have that case manager or that secretary at the school just go back and mark that IEP locked as signatures come in on the paper documentation. And then the other issue that we do see in a lot of cases is over-limit services. And this is when services are delivered over the duration or the unit limit of the IEP. So again, going back to that service calls for 60 minutes weekly, and the provider is documenting 90 minutes weekly every single time. If you do use a web-based system and it can account for this, for example, our system does allow the provider to document that 90 minutes and will only bill for 60 so you don't run into any audit issues in the end. But you do want to track those over-limit services, because if you're seeing that for a particular student on a consistent basis, that's where you want to go back and amend that IEP, increase those minutes, and be able to recoup the revenue for those. Okay, so let's go back into some of these examples with a little bit more detail. Transportation and personal care services. So why are those excluded from the billing practices in many districts? Now, first off, they may not be available in every state. These two services in particular are left out of quite a few state plans, but where they are included, we still only see a very low level of participation in these service types. So it's a pretty easy pitfalls. Or to understand, I should say. It's a lack of computer access mostly. Your bus drivers are obviously driving. They really don't need a computer for their job, but they can't get to a computer to record who was and was not on the bus. And you do need that trip attendance to accurately bill a Medicaid. And personal care workers are with students day in and day out. These aren't individual sessions they're conducting. They're typically with, a group of students or one student all day long, assisting that student with toileting, feeding, transferring from room to room, monitoring for seizures, or whatever the case may be. And so they're not going to be able to go in and log their time at a computer. And even if they maybe did have a few minutes at the end of the day, there may not be a computer they have access to. So the questions you want to ask yourself about billing transportation and personal care service are, is there a method of documentation I can provide this personnel outside of a computer? Can I give them some kind of form? Perhaps. And then if I do, how will this information be transferred to my billing system? This is where I'd like to make the case for a scannable form. This is the most versatile solution that we've been able to find across our districts, and we actually have scannable forms for both of these service types in our system. So this is an example of our bus driver form. Every week, districts that employ this send us files of the bus driver information and the students that are on each route, and the bus driver receives this form every week. They simply check off who did and did not attend the bus that day, and then this is scanned directly back into our system and verified by an administrator. Once it's verified by that administrator, the trips of attendance, anywhere the boxes are checked, are lined up to the paid services and claimed to Medicaid. So let's go on and talk about parental consent. So first off, obtaining a parental consent is probably one of the most important things that your IEP teams can do when it comes to bringing additional revenue into the district. And this is something that really should be trained annually. We see this a lot in districts. Everybody has a different idea about what parental consent actually means. We've even seen some teachers and some case managers believe that when a parent gives consent to Medicaid, that's going to actually affect their personal Medicaid, which is not the case. And they'll actually give wrong information to that parent in the IEP meeting. You don't want this happening in your district. So clarifying those regulations and reinforcing those and removing any kind of telephone or rumor mill is very, very important. And it's something you want to do on an annual basis so that if you do have a case manager or somebody coming in from a different district that didn't have this practice and is coming in with this information retained from their old job, you want them to come into your district and be trained and know what they can say and what they're safe in saying. And then the next thing that you want to do is you want to put that in writing. And you want to put that in writing for two reasons. You want the person explaining these regulations and you want the person hearing these regulations to both know that those are backed up by the state and that the district is taking full responsibility for these words. So we do encourage you to have some kind of documentation, an FAQ, or even include it on the Medicaid consent form. And as we can see here, this is a sample from the New York City Department of Education, the Medicaid consent form itself does describe how those regulations work and the protections the parent receives, so that everybody is on the same page about this issue, and there's no there's no kind of confusion with what rights they have, what protections they have, and there's not multiple people talking to them and saying, oh, I heard this, etc. So questions that you want to ask about your parental consent practices. And this goes back to more, how is my data being managed? So first, is your district using a lifetime form or an annual form? Back in March of 2013, the federal government issued new guidelines saying that parental consent no longer needed to be collected annually. For a long time, it was only valid for a single year. Now it is valid for the child's lifetime in the school district. If the student does change to a new district, you do need to collect new consent. And if the level of services in the IEP does change substantially, you also need to collect new parental consent. But so long as the student's getting a consistent level of service, that consent is lifetime. You do need to issue an annual notice. That it has to be acknowledged that says, we are continuing to bill for students that have received the lifetime form, but you don't need to obtain new consent again using that same form. So if you are using a lifetime form and your IEP system has updated to that lifetime form, we have seen some systems that are still on the annual form and therefore require districts to collect annually despite these new regulations. Does your IEP system still require that lifetime form at every annual meeting? Now, what's the risk of this? Well, in a lot of ways, it can be risky because, again, you go back to every single time you're collecting consent. That's a very touchy subject, especially if you're collecting it at the IEP meeting. It may have been very contentious. And then you have to go and discuss money. And you may have the parent be upset and say, I don't want to give the school district anything right now. I'm not happy with the level of services they're providing. And they deny the form. Or you have a different parent in the room this time that feels a different way about this process and denies it. Or you just don't have a case manager or a therapist or teacher that explains it in the same way that it was explained the year before. And consent is then denied. You don't want that consent once given to be rescinded. So as much as possible, you want to limit that collection. If it's not required to collect it that second year because it's already there and the service levels haven't changed, then that should be a process you can bypass if you're using a system. Now, what options do your IEP teams have to track parental consent? We do see this vary from system to system. In our system, for example, you can monitor yes, no, or not on file. Maybe somebody forgot to do it, or something like that. And we do have those statuses so that in our system, if we are talking to another system that doesn't require collection at that first meeting, you can track it. We've seen quite a few systems, IEP systems that we work with that only, where our districts are only contracted with us for a documentation system that don't require the IEP consent to bill at all. And so we do always want to monitor when it's not collected or when it's even just not submitted to us. Okay, so next, if parental consent is refused or if it's not collected, does your district have a follow-up process? Or is it simply decided that it was refused or not collected at the IEP meeting, and this won't be approached again until the next IEP meeting? You could be missing out on a lot of revenue if you don't have that follow-up process. Going back to that annual training, if you don't have the time to have the annual training every year, you should at least train a small handful of people that can follow up with those refusals or those not on files, that can try and speak to a parent in a different way, that are definitely coached on the way to approach this what can be a very sensitive subject. And then how are those efforts prioritized? Do you just give this follow-up personnel, if you do have them, a list of students with refusals and not on files? Or are you able to tie that information to the potential revenue for each student so that they can target their efforts to the students that would bring the district back the most money? In our system, you can actually track the amount of parental consent missing and the revenue you're missing for those students. At the student level, you can monitor at the school level to see which schools are better or worse at collecting that parental consent initially. And it will definitely give that follow-up personnel, should you have them, a way to prioritize their efforts, to say, who should I call first? Who should I put my best person on? Finally, just a simple matter, where and when do you issue that annual notice of continued parental consent to ensure full distribution? We definitely recommend that you just send it out with the annual school guide at the beginning of the year. The parents tend to have to sign and send that back, and that's your full acknowledgement that parental consent is continuing, and you have that notice in there. And then, how do you analyze the impact missing parental consent has on your revenue? We've discussed how you do it in our system, but as a whole, if you aren't using our system, you should definitely find a way to analyze that impact. Can you look at the services you would have been able to claim had you had parental consent? Is there a way to monitor that information in your system? Now, let's talk about prescriptions. We've seen OT and PT prescriptions collected two different ways. So the first question you want to know is, who is collecting the prescriptions for OT and PT services? The one way we've seen it done is that all students that receive these services are collected together at a central location. And then after a certain number of forms are collected, those are sent to a single doctor, and prescriptions are written for all students. And this has a couple of pitfalls. One, just that process alone can delay billing. If you do have a small number of personnel handling this, they may, they tend to want to collect those at a certain regular interval, send them off at a regular interval, et cetera, et cetera. So then you're going to have this institutionalized delay or loss of revenue, because they're going to collect it for 3 weeks, and then you're going to have 60 kids in 3 weeks that were sitting there for 3 weeks until that last day hits, and they send it off to the doctor, and then the doctor sends it back. The other thing that we see happen is that if doctors are receiving a high number of IEPs for prescriptions they have to sign off on, they charge for that. So that's going to cost the district even more money. Now, this may be the only practice that you have to do this, because you may not have providers that are equipped with this. But where we do see providers collect prescriptions directly from the student's personal physician, we see better results, and we see faster results. But you do also need to make sure that those providers are trained and that they're aware of what they need to do. So they're ready as soon as that IEP meeting happens to hand that prescription to the parents or fax it to the doctor, or whatever the case may be, to obtain that prescription. Now, involving the parents may be difficult in some cases, but again, this goes back to making the parents understand that this is not going to affect the student's services, although in some states it does prohibit the actual delivery of physical therapy services. But outside of those states, it's really just about making the parent understand that this is something that you need to ensure that medical necessity, and not relate it back to parental consent to bill. Now, when this is collected by your providers, the biggest thing we see happen is that delay in revenue. The provider collects it, and they keep it in their folder, and they don't pass that information on. So you do want to make sure that your OTPT lead, or whoever is managing your Medicaid process, does have a system for monitoring who has received OPT and PT services and what prescriptions have come in. And again, in our system, you can monitor which services are being provided to any student and where prescriptions are not available for their services. So you can track which students are missing prescriptions. But if you don't have a system that houses this, you are going to want to devise a system to do that for yourself. And again, how do you measure the impact of missing prescriptions? Just like parental consent, if you don't have a report like our system has that can just say, here's every service that could be billed, should a prescription be in place, you do want to see if you can find a potential impact to that revenue and look at the services documented, the duration they were documented for, and try to analyze how much is being lost. And that may give you incentives with your finance department or whatever the case may be to allocate additional resources to managing this process. So we've talked about a whole bunch of things that you can do, but when should you do them? What we recommend is that on a monthly basis, you review documentation for compliance levels. Make sure providers are documenting all the students on their caseload and that all that service documentation is complete. And that you follow up with providers on a missing documentation and let them know that you've noticed it's missing and it needs to be entered so that they know that somebody is watching and that the recording of their services is being monitored, and if that does factor into their performance reviews, it will definitely incentivize them to document. Also, on a monthly basis, we recommend that you submit claims to Medicaid and that you submit eligibility, and you submit that retroactive eligibility. And when you're doing claim submissions too, we do really encourage you to submit retroactive claims. We find in so many cases, just because of missing data, late prescriptions, etc., about 40% of the revenue for our districts comes in through retroactive claims. If you're only submitting 1 month and then you're letting that month go, you're not getting all the revenue you can. And going back to that full back billing period and knowing what that back billing period is highly beneficial to maximizing your revenue. And again, we recommend that you, on a monthly basis, review revenue exceptions from the previous month. If you've been following up with providers on missing prescriptions or missing parental consent, or if you aren't seeing a large increase in parental consent exceptions going down, maybe it's been at about the same level for a couple of months, in fact increasing, that's where you want to go and revisit with your follow-up team and say, hey, have you been following up with parents? Have you been able to get the parental consent for our highest grouped kids that are bringing in most of these exceptions? You know, what's been the process? Is there ways that we can improve this? Now, on a quarterly basis, you want to definitely review and resubmit your Medicaid denials. You want to be able to look at those EOB codes and say, okay, what can be resubmitted and what can't. We'll see a lot of denials come through in our system that just can't be resubmitted. Perhaps a student was only eligible for family planning Medicaid, and so a speech service was denied. Or the student had a duplicate service. They already had a service from another provider on that day. So you do want to review each of those denials and look at the ones that can be resubmitted. The thing we see most often that can be is an invalid diagnostic code. And in our system, that is limited to a select number of entries so that the providers can't actually type in diagnostic codes. But if you do have somebody that has access to that point and does enter a diagnostic code incorrectly, they key it wrong, or they don't check for billable status first, you may see some of those denials. And you'll definitely want to visit who has access to that page so that you can make sure that they know the process for verifying a diagnostic code before it's entered into the system for provider selection. And you'll also want to review on a quarterly basis documentation levels against those called for in the IEP. So you do want to make sure that as providers are documenting and you're reviewing those services monthly, that they're documenting everything that the IEP calls for. You don't want a provider accidentally thinking a service needs to only be delivered once a week for 30 minutes when it's twice a week or something along those lines. And you also want to just review this for documentation purposes in general. No provider is probably ever going to deliver 100% of the services the IEP calls for because there's just not enough time to do so. Students are absent, there's school holidays, etc. But you do want to make sure that they're documenting why services weren't taking place and be able to review the minutes that were recorded against the minutes that were due in the IEP so that you know all of those are accounted for. And our system actually has a report that does that for you that we call prescribed versus delivered. And it tallies every single minute and the status that was attached to each minute against what was prescribed. So you know exactly where that time went that the student was owed. And again, quarterly, you want to follow up on those parental consent denials and make second attempts. This is definitely something that you'll want to do as much as possible, at the very least quarterly. And then you'll also want to connect with your providers, and this goes back to incentivizing providers. Discuss the documentation protocols with them. See if you can refine processes. See if there's something that you missed in that initial implementation of this process of documenting all IEP students that they're still doing that's duplicating their efforts. See where you can reduce documentation burdens. And make them feel included in the program so they want to participate more. And finally, on an annual basis, you want to train all your providers on the best practices for documentation and train your IEP teams on the best method to collect parental consent and the best methods to manage prescriptions. Now let's look at a few case studies. Hampton City Public Schools became a client of Excelify in the 2012-13 school year, and Hampton fell into that first revenue exception that we discussed. They weren't claiming for a whole bunch of service types: nursing, personal care, social work, psychology, and transportation services. With us, they implemented ExceloPlan, our IEP system, ExceloTrack, our documentation system, ExcelPCS, our personal care scanning form system, ExceloRoute, our transportation scanning form system, and ExceloClaim, which is simply our claim processing system. And the end-to-end nature of the solution resulted in a whole bunch of improvements in the district. They were able to more effectively manage their IEP and 504 development processes with our ExceloPlan system that actually guides the IEP deadlines for everyone. They were able to automate their means for tracking IEP timelines and completing plans of care. And they were also given better tools for monitoring service documentation and delivery so that they could go back and revisit with providers that hadn't been documenting services. And this led into a 300% increase in their fee-for-service claims, and also led to 2 times the cost settlement payments, with about $70,000 in additional payments received just for transportation. Now let's look at Chesterfield County Public Schools. They had no Medicaid claiming program prior to working with our company. And so what we did initially was conduct an extensive provider-focused training to get the district up to speed. We reviewed Medicaid regulations. We went over how the system works and the protocols, and reviewed the benefits of claiming these services and the impact that it would have on their district as a whole. And then, through the course of the next year, we reviewed all the revenue exceptions, namely parental consent, which had never needed to be collected and was a brand new process for their IEP teams. We worked with them to analyze which schools had the best collection operations and which ones needed additional assistance, and help provide guidance on how to best capture parental consent and get those forms signed, while helping them target their efforts towards the students that would bring back the highest revenue. And by year 2, they've received over $700,000 in revenue. Now let's look at Broward County Public Schools. With their prior vendor, they documented about 300,000 services, but moving to Excelify, they were able to double that documentation just with additional monitoring and oversight and the ease of access in our system. And then same thing with transportation. Using our scanning forms, they were able to increase their form documentation for logs from about 150,000 to over 1 million. And this led to a 100% Medicaid revenue increase, which definitely benefited the district and their special education department. All right, thank you so much, everyone, for your time today. I really appreciate it. And back to you, Emily.